In the blink of an eye, the world can change. Next, On Call with the Prairie Doc.
Good evening and welcome to On Call with the Prairie Doc. We think of our vision as something so important that we often separate it from our everyday health concerns. But the truth is that there are many things, including what we eat, our exercise routines, and the physical environment around us can have an impact on the quality of our vision. Proper vision care needs to be part of our daily lifestyle choices. Okay, let's take a look at this week's Prairie Doc quiz question. True or false? Smoking is linked to an increased risk of developing age-related macular degeneration, cataracts, and optic nerve damage. True or false? Call or email your answer now. We'll take quiz answers for only the next 10 minutes of our show. Viewers who call in the correct answer will be entered into a drawing to win a signed copy of A Picture of Health. This book was written by me and with accompanying photographs by Dr. Judith Peterson. We'll announce the answer and the winner at the end of the show. Remember, you have only 10 minutes to get in your answers, so answer quickly. And then we want your questions. We answer your questions as they're called in or sent to us via Facebook or email. Call in questions to 1-888-376-6225 or send us an email or answer the quiz and have a question. So thanks for joining us. And joining us tonight, we have eye specialist Dr. Eric Thomas, a retinal specialist from Ophthalmology Ltd.
Correct.
And Vance Thompson, the front of the eye specialist from Vance Thompson, and so vision. And we have the back of the eye, the front of the eye. We've got all the questions covered, and we need your questions. So let's start with Vance. Tell us a little bit about yourself, Vance. Where are you from originally?
Well, I graduated from high school in Gregory, South Dakota, went on to USD and studied chemistry in med school, and after med school became really interested in the eye. And actually, one of my mentors was Eric's uncle, who helped me along the way, and he had went to USD School of Medicine also and was a great eye surgeon. And
he was an undergrad partner and friend of mine as well,
Wow.
Byron
yeah.
Home.
That's what I love about South Dakota. It's all connected.
Yes.
And then I went on to the University of Missouri Columbia and did my eye surgery training, then did a fellowship in refractive and cataract surgery. In Kansas City, got involved in the research and development of lasers and implants, and have just really enjoyed taking care of eyes in Sioux Falls.
That's great.
For people from all around.
All right.
Yeah.
And you were really the first guy to do LASIK refractive surgery in the state of South Dakota and the region, really, wasn't it?
Big part of my research, and to tell you the truth, it's an honor for me to be here tonight with Dr. Thomas, because I refer my retina to him and his partner, Dr. Ryan Garrett. So it's a special evening for me to be here.
Thank you.
Thank you.
And Eric, tell us a little bit about yourself.
Well, I'm from Aberdeen, South Dakota originally, and ended up going to Augustana University now for my undergraduate degree, and also went to University of South Dakota for medical school, and also did my ophthalmology training at the University of Missouri Columbia. And then following that, I did a vitreoretinal fellowship out in Lexington, Kentucky. So, and then following that, decided to come back home to South Dakota, and been back here ever since. Yeah.
So, and both of you have seen me in your offices. I appreciate your expertise, and so I'm talking about my doctor, and later we'll see where I get cataract surgery by Dr. Ken Knutson from Brookings. So I've got a little bit of eye issues, and I'm so glad I've got good doctors. Our show discussion is driven by you. Please call in your questions about anything related to vision at 1-888-376-6225 or send us an email. Well, let's talk about anatomy. I would like to start with, I'm going to do the first drawing, okay? So we'll do a circle. This is the eyeball, and I'm going to start with you, Eric. Show us what part of the eye are you involved with?
Or are we looking sideways here?
We're talking sideways.
Okay, so if you're looking sideways, where Vance is going to be talking about is he's going to have the cornea up in the front, and this is going to be the back of the eye over here. So this is the optic nerve leading inside the eye here. And what I deal with as a retina specialist is the back inside wall of the eye in here. And that's what we call the retina. So the eye itself is filled with this kind of gel material called the vitreous. It's kind of like the consistency of egg whites, and that's what fills the inside of the eye, and that's actually connected to the retina. So when we talk about different retinal conditions, that's why they call me a vitreoretinal specialist, because those two structures are integrated together and have a lot to do with each other.
So how far forward does the retina go?
That it extends, basically it originates from where the nerve comes into the back of the eye, and then extends up to an area up here where it kind of stops. That's called the pars plana. So when we do surgery, when we're doing surgery in the eye as retina specialists, that's the part of the eye that we go into right there. Because when you enter the eye through that area, you're not going through the retina, and that's a bad thing. If you go into the eye to do work in there and you're putting instruments through the retina, you're causing a lot of damage, so we don't want to have that. So.
Okay, all right. So Vance, it's your turn. I'm going to turn you into a green line. So where are you involved? What do you do?
So, let's say the pupil's right here, and then we have the cornea.
Now the pupil is just a hole, really. It looks like a black dot, right? But it's just a hole, isn't it?
And it is just a hole, but it has very important functions. It's really wide at night to let more light in, and it's really small and in bright light, so that you aren't so light sensitive. So it's a variable, aperture. And what happens with it, as the light goes through the cornea, the front window of the eye, it is focused by the cornea. It's also focused by the lens that sits right behind the pupil, that's anchored by some filaments that we call the zonules. If you look straight on at the lens, it almost looks like a trampoline. And these would be the trampoline springs, the zonules. And so the cornea provides 2/3 of the focus power of the eye, just because of its curvature. And majority of that focus power happens right where the air meets our tear film. That's why dry eye patients have such blurry vision. The tear film is the most powerful focusing element of the eye, right where the air meets the tear film. And so the other third of focus power, besides the cornea being 2/3, is the lens. It provides 1/3 of the focus power, but it's a very special focus power that's variable. So when we look at a distance, it's flat. When we look up close, that lens will zoom in until we get in our 40s, and it starts to get stiff and stuck at a distance. And then when we go to try to read, it just won't read, and people drift into bifocals or reading glasses. And that's the first thing that goes wrong with that lens, is it gets stiff. The second thing is it gets cloudy, and that's a cataract, which is a stiff, cloudy lens.
Right, okay. And I would add, we can say a lot about this wonderful tear film, because as I was reading about tear film, it isn't just sweat, or it isn't just salt water. It just isn't water. There's a protein in it. Part of that feeds the cornea, because the cornea is alive, but it doesn't have blood vessels to it.
That's exactly right. The tear film has nutrients. It has oxygen. Yes, it lubricates. It has antibodies to fight infection. And because of the oxygen it carries, I do think of it like the blood of the cornea, because the cornea is clear without blood vessels. And that's why the outside of the eye is nourished by the tear film. The outside of the cornea is nourished by the tear film. The inside of the cornea is nourished by what we call the aqueous, which is a fluid that the internal eye produces.
So, and that's in here.
Well, exactly. The aqueous is in there. Yep.
Okay. So, and this lens,
Yes.
Vance, is that smack dab up against the hole of the iris?
Well, in bright light, when the pupil gets small, the iris does rub along the lens. And in some highly nearsighted people, the approximation of the iris to the lens can be so much that the pigment on the back of the iris can be knocked off. We call it pigment dispersion, and then it can get into the little glaucoma drainage channels that are right where the cornea meets the iris. We call that the trabecular meshwork. And if something starts to clog it, like pigment, it can start to raise the pressure and develop a glaucoma. And so there's various types of glaucoma. because of the resistance that can happen in that drainage channel.
And that would be called narrow angle glaucoma?
Well, that would be called pigment dispersion glaucoma. In narrow angle, that happens when, the lens gets really big and it pushes the iris forward and it actually closes off this angle. And then we put a hole in the iris with a laser. And then that allows the fluid that's being made behind the pupil to get to the front. It opens up that angle and it cures narrow angle glaucoma. But sometimes for narrow angle, we got to remove the large lens. It's oftentimes a large cataract, and then you get that out, and then the iris and the cornea can separate, and that angle is nice and open then.
Okay. So let's go back to the back of the eye as we're talking anatomy and talk about the vitreous. Eric, tell me a little bit about that sac of fluid inside the eye, the vitreous.
Well, like I was mentioning before, that vitreous just basically fills everything behind the lens that Vance was just talking about. So all this stuff back here is the vitreous. But when you think of the vitreous, most people think, well, it's just that fluid that's inside your eye, but it's not just freely floating in there. It's actually a bag of gel. And that bag of gel is actually connected to the retina all along the back, okay? Now, over the course of your life, as you're looking around, that stuff is always sloshing around in there. And when you start to get into your 50s and 60s, the vitreous will kind of start to collapse in on itself a little bit. And what happens is it'll start to separate from the retina. And that's a normal process. And at some point, it will pull totally free of the retina. And when that happens, that's a condition we call a vitreous detachment, which sounds really scary because it sounds a lot like retinal detachment.
Right.
But it's not. It's a totally normal thing. And that's probably the most common reason for why we see people for flashes and floaters in that age group, because as the vitreous is pulling free from the retina, it's kind of tugging on the retina a little bit. And the retina doesn't feel pain, it just senses light. So as it's being tugged on, that kind of stimulates these little flashes of light. And when it finally separates from the retina, that gel will kind of clump up on itself. And that's why you see these little floaters. But you do, when people notice that happening, they should go in and see their eye care provider to get that looked at, because although that's a normal process, if you have thin areas in your retina, if that vitreous is pulling hard enough when it's trying to separate, it can rip or tear the retina. So that's why we always want people to come in and get that looked at to make sure we don't have any issues with that. So.
Right. And in my case, I was losing my focus, the central focus, when I was having that vitreous separating.
Correct.
And that's the trouble I got into. Well, let's talk about the big four. People talk about the big four problems, and we'll just start at the top. Really, cataracts is probably the most common thing that we run into. And cataracts happen for what reasons? I mean, some people get cataracts as a younger person. Some people are very old and they don't have cataracts. Why do the lens not opacify in some and opacify early in others?
Well, the bottom line is eventually everybody gets cataracts. And so when you hear the diagnosis of cataract, you don't need to necessarily think, I have to have it removed. About 30% of cataracts need to be removed. And they happen for various reasons. The most common reason is age-related. And there's little cells inside the lens called lens epithelial cells. And they make these protein fibers that continue to be deposited in the lens over the years. And that's why it thickens and thickens and eventually gets so stiff that it's not flexible. And eventually it not only gets stiff, but it gets cloudy because there's so many of these protein fibers. And that's the most common cause of cataract. And if everybody lives long enough, they get cataract. So again, don't feel so bad about a diagnosis of cataract. But if something leads to trauma to those lens epithelial cells, whether it's steroid eye drops or something that's oftentimes implicated, if they're used for a real long period of time, in short bursts, they're fine. Or people with bad asthma that need to be on oral steroids for a long time, or some other, illness that they need long-term steroids. Smokers can get cataracts. And there's other, what we call metabolic diseases, where people are missing a certain enzyme or something. And so there's multiple reasons for a cataract. But one of the beauties is it's one of the most successful surgeries known to man. Again, most people don't need the surgery when they have a cataract, but for those that do, literally one of the most successful surgeries known to medicine.
And the question that I'm often asked, is how bad does your vision have to get? When do you know to go forward with the cataract surgery?
Well, in the old days, we used to hear about patients needing to wait for the cataract to get ripe. And so patients would actually suffer long periods of time because it wasn't maybe ripe enough for the surgeon to remove it. What's happened over the years as surgery's been done with better instrumentation, smaller incisions, less trauma to the eye, quicker recovery, we've gotten to the point where if a patient is not happy with their glasses corrected image and it's affecting their joy in life, and it's from a cataract, then it's a reasonable time to be talking about cataract surgery. So it really has to do with how it's affecting a person's life and their joy.
Yeah, and all I can say is that when I came out into practice, a lot of people had big, thick pop bottle glasses.
Because they didn't have an implant.
Because they took out the cataracts because their vision was so bad, and but they had to have lenses to replace it. And the implants came during my lifetime of practice.
It changed everything. The implant.
It changed everything.
Yep.
Let's take this package. As we age, it's kind of a funny story. As we age, it's common for the lenses of our eyes to begin to cloud over, sometimes to point of becoming cataracts. So I found out firsthand how the surgery for cataracts has improved.
So procedure only takes 20 minutes or so.
Well, today you saw Dr. Holm getting cataract surgery. And that's where we remove the cloudy lens in the eye and then replace it with what's called an implant lens or a man-made lens, which helps clear up their vision. Once you remove that cloudy lens out of the eye and we put in that implant lens, that's permanent and that just stays in the eye for the rest of the person's life, barring something unusual like trauma, but it's not, the body is not bothered by having that material in there. It doesn't cause any rejection problems or anything like that. We have the person use some antibiotic drops and some steroid drops to control inflammation. But we're checking them on day one and then usually a week later to make sure they're not having any problems. Most of the time, problems are very, very rare. The main bad one would be an infection inside the eyeball. And that's why we use the antibiotics and we see them back, but that is very, very rare, luckily. Very common operation. In fact, numbers-wise, I think it's the most common operation in America. Almost all of us get some type of cataract as we age, and if you live long enough, you're probably going to have surgery to remove it, and you have two eyes, therefore making it very common surgery. Well, I just say overall, the procedure nowadays is only about a 10 to 15 minute surgery. Very easy to go through, not much pain afterwards. It doesn't lay the person up very long, which is nice. So in general, it's as far as surgeries go, it's quite easy to go through, and the results are usually fantastic. Patients are so happy when they get it done, and it makes for a nice surgery for the doctor also, because patients are happy and they didn't have to suffer very much. So.
There you go. We had a hard time talking that patient into letting them take photos of the whole story, but he finally was willing to go through with it. So here it was. What's your response? You said it's different than it used to be.
Well, just Vance and I were kind of talking in the background as we were watching the video, and it's just, we both just really love what we do, and it's very interesting to see how ophthalmology as a whole has just changed. It's one of the fields that's just grown exponentially, really in a short amount of time, really. I mean, when I was in my training, which wasn't all that long ago, when we were doing cataract surgery, you had to take the lenses and kind of fold them and make a big incision and slide them in there. And now you can see in the video that when you were having your surgery, they're able to inject them into the eye through much smaller incisions. And it's neat to kind of see that, even as a retina guy. So that's.
And I have to say that after a lifetime of not being able to read the clock in the middle of the night, and having to, stumble across the room, and finally I moved the clock right next to my, and then finally I shone a big, huge clock on the top of the ceiling that's huge to be able to read what time it is in the middle of the night. Now, with cataracts, my eyes are much better with their vision. It's just an amazing thing. I mean, how many changes have occurred with cataract surgery during your time?
Oh, amazing. I think literally the dollars that are invested in the world of vision are so large because vision is such a precious sense. You know, what we do is, to most people would say it's their most precious sense. And so, you know, the changes I've seen have been astronomical, from, you know, being able to correct nearsightedness and astigmatism and farsightedness with a laser, to being able to, you know, restore something that eventually frustrates everybody, and that's the loss of the ability to read. And that is this idea of what we call accommodation, our natural lens, helping us read at distance and near. To see implants, you know, now get to where, you know, patients are really able to enjoy it. That's been absolutely amazing to me.
It's just, I mean, and I'm happy that I'm in this era to be able to gather the value added.
They're even starting to do, you know, artificial retinas. You know, Eric works so hard on preserving the retina. Well, some things like retinitis pigmentosa, you know, there hasn't been anything you could really do for it. And this early work of artificial retinas and people actually able to see shapes,
right.
It's a new era of that.
Right.
Yeah, it's
Totally
unbelievable.
blind, and now they can see shapes.
Something, yeah, which is, I mean,
Yeah.
something is amazing for those people who literally saw nothing.
Yes.
Yeah.
So,
I was listening to that on National Public Radio as I was jogging, thinking about holy Toledo. I mean, it's sort of like the hearing implants, the people who have the cochlear implants. I mean, when they were totally deaf before, now, of course, there's some learning that you have to go with it.
oh yeah, and there is for that too with the artificial retina. But a lot of that is, it's almost computers,
Right.
Because now as they're getting more sensitive sensors in the eye, I mean, that's just going to grow exponentially. And as they get better at that technology, I mean, they've kind of gotten past those first hurdles, and now it's just going to be time until each iteration of that continues to improve on itself.
Now, isn't it that the photoreceptor is really in your glasses, and that
Well, it's in an array that they actually implant into the eye.
Oh, really?
Yeah, it's actually implanted into the eye under the retina. But then there's a transducer that sends it to a transmitter that's on a pair of glasses. So it's pretty interesting. It's pretty complicated to get into right here, but it's really interesting. And you can find, there's a lot of good information on it, you know, online and things like that.
Just Google artificial retina.
Yeah.
One of the exciting South Dakota connections, you know, we have a national holiday coming up this weekend, the opener of pheasant season.
Yeah, it's a
And-
national,
yeah.
well, South Dakota holiday, that's for sure.
But one of the inventors of you know, this artificial retina, and one of the companies is called Second Sight, is actually going to be hunting with me.
Oh, really?
Yes, yes, and
so-
he's from the San Francisco Bay Area, and just a brilliant man who is bringing hope to people who've lost their retina.
Ah, that's fabulous stuff. Well, let's kind of do another shift. Let's talk about loss of vision associated with diabetes, because that's a big one. We'll see a lot of that. How does that go, Eric?
Well, really, that affects both Vance and I, because people with diabetes also tend to get cataracts earlier in life also. But really what you hear about with diabetes and loss of vision is typically what they call that diabetic retinopathy. And like we were talking about earlier before the show, in people with diabetes, they just don't have great blood flow in the eye. And you can imagine the blood vessels in the eye are just so small that can cause damage pretty easily. So when the blood vessels get kind of weak because of the diabetic changes, the blood vessels can break and bleed. They also get kind of weak and leaky, so they'll leak fluid into the retina and make the retina kind of swell up like a sponge. Yeah,
We have a picture, so they have spotty loss.
they can, because it's frequent that you can get hemorrhaging in the eye. And a lot of those people will experience kind of blotches in their vision like this. But a lot of times it can just be diffusely hazy, because when that central vision area of the retina starts to swell up like a sponge, it's just not able to focus. So that's what they call macular edema. And that's probably the most common reason for people to lose vision early on in the diabetic changes.
Kind of what I was having.
You had macular edema, but for a different reason, correct?
Right. So it's interesting that the body is trying to replace the loss of blood flow with neovascularization. So they put in new little vessels,
Yeah.
trying to replace it, try to heal an area that doesn't have blood flow. But these little neovascular tufts are so fragile, and then they
Correct.
break and bleed.
Yeah, well, they'll, it sounds like a great idea. Let's just grow a bunch of new vessels and get more blood into the eye,
Yeah.
except they're abnormal. So when they grow on the surface of the retina, then they'll grow up into that gel that we talked about, the vitreous that fills the eyes. It'll grow on it like a scaffolding, basically. And you can imagine if these vessels are really fragile, which they are, and you're looking around all day, that stuff's it's just yanking and tugging on them, and they break and bleed, and that causes what we call a vitreous hemorrhage. So that vitreous cavity will fill up with blood coming from these abnormal vessels. And that's usually when we have to sometimes do surgery to go in the eye and clean that blood out with a surgery we call a vitrectomy.
So here's my question that's, I think is, so if I'm diabetic and I want to do everything I can not to have that, not to lose my vision, I want the very best vision. There's some who have said, well, if you're diabetic, I don't care how tightly controlled you are, you're still going to have this. Some people say, no, it's less if you get it tight control. What's your take on
It's
that?
definitely less if you control it better, definitely. However, the eyes sometimes do kind of have a little bit of a mind of their own. I have many patients that do a great job controlling their diabetes, but even if you're controlling the diabetes, there's baseline damage going on there, with the disease process, and that sometimes can catch up to you. But every study ever done has shown better control of the diabetes, better chances to keep good vision.
All right. And the front of the eye is affected too, Eric said.
Yeah.
Well, how so, Vance?
Well, what happens, especially when blood sugars get real high, there's a shift of fluid into the lens. And so it can make someone who is, has normal sight or farsighted, it can shift them towards nearsightedness, and they can get these fluctuations in their vision based on their blood sugar.
Yeah.
And then the other thing that happens is the sugars can get deposited into the surface layer of our cornea, the epithelium, and just like the friable blood vessels that Eric's talking about, the epithelium or surface layer can become friable, and you can get frequent abrasions and painful episodes.
So those are, so it's a good idea to have good control of your diabetes. I noticed that a person who is normally well controlled runs 120, 150, a diabetic, but running pretty good, and then something happens and they go 300, 400 for a while, their vision goes out of whack because the edema in
The swelling of the lens,
We've got some questions, and we'll go where you people take us. And so I'm again calling you to bring us your questions. A 66-year-old man from Edgemont. I'm interested in the cost, safety, and results of LASIK eye surgery. 66, is it a little late for that?
I can get this one, Vance.
You're one of the LASIK experts in the country, but Eric could answer it.
Well,
no, go ahead.
I'll defer to Vance.
He is
on that
brilliant.
one.
So, but this when you're 66, the one thing that we want to look at first is the health of the eye, and that is there an early cataract? Because if there is, you basically want to probably wait for cataract surgery. And a real simple test on your end is if you see good with your glasses, and you of course see bad without them, and you want to see good without them, you are probably a good LASIK candidate. But if you're frustrated with your glasses corrected vision and you got those best pair of glasses, LASIK is probably not going to give you the vision you're looking for. But let's say you have the vision with the glasses, you're happy with it, and you want to just see that good without them. Then we start talking about LASIK after we do a good exam, make sure the corneal curvature is normal, the internal eye health is good. And then we say, you need to understand the technology. And this is where doing some research is really important, because you can get LASIK done very inexpensively. And when I see someone sitting in my center who's been hurt at a low-cost laser center that wishes they would have done some research, they all wish they wouldn't have done it, or did their research before their surgery and did it right.
So what's the research exactly?
Well, when you look online, there's wonderful websites that talk about the various types of technology to make the flap, the various types of technology to laser correct the nearsightedness, or various technologies to measure aberrations that affect, or irregularities in vision that affect low light image quality. And so there's all these things that go into a vision correction procedure that a person wants to understand. There's good, better, and best technology, and then you have a decision to make how you want it done. And the price will range anywhere from, you'll hear it for $500 an eye, and you'll hear it for $3,000 an eye. And what you need to do is you need to do your research and understand the technology that's going to be used, and then you have to make a value decision for yourself.
So very quickly, draw a picture of how it happens. What is it that's going on?
With an eye that's basically, let's go with the little red there. Let's first draw the eye, the cornea, the sclera, and we've been through some of this, the iris, and then we got the lens, and it's anchored by the filaments, and then we got the retina in the back, and we got the optic nerve that's going to take the message of vision to the brain. But the cornea has a certain amount of thickness to it, and basically we want it to be thick enough to be safe for surgery. Because what happens with light is when light rays come into our eye, they're focused by the cornea and the lens on the retina. And if they're focused just right, the focal point happens right on the retina. This person wouldn't need glasses. But what happens in nearsightedness, this cornea is too curved and the incoming light rays are bent too quickly. And so what happens is that the focal point happens way too soon, and by the time it gets to the retina, the image is defocused and blurry. And so in laser vision correction, what you do is you take this cornea and lessen its curvature so that, because a cornea oftentimes has about 45 units of curving power, so to correct a 5-unit nearsighted person, you got to reduce the curving power from a 45 to a 40. And then the curving power, and very sophisticated math with the laser does this, allows the image to now happen on the retina, and the person can do their functioning without glasses.
So do you make a flap, you cut it in between, and then you lift this flap up?
That's exactly right.
Maybe we should erase and start again.
Yeah,
and
no,
see how does that go? Okay.
I have an idea here. So let's just draw just the cornea. So, and now we've drawn just that front window of the eye. And let's say that we're going to we can do laser vision correction on just the surface. We call that PRK. We can first make a very thin flap, and then we lift up the flap and then perform the laser, and we call that LASIK. So we got PRK, which stands for photorefractive keratectomy. We have LASIK, that stands for laser-assisted in situ keratomileusis, and that's the flap and laser. But you want to remember another powerful way, because some people are too high of a correction for LASIK or PRK. And then what we do is we don't operate on the cornea, and we take the internal eye, and we don't remove the lens in a lot of these patients because they're young and it's still functioning well and reading well. And we can put a very nice little inside the eye contact lens that sits right over their natural lens, and there's one that sits right over the pupil, and you can correct 20 units in nearsightedness, huge corrections for people that didn't have the option of laser vision correction or glasses. And then finally, you can replace the lens. And if there's early changes happening in it, that's oftentimes the best way to help someone see without glasses is lens replacement. Right. So all those options.
All right, that's great. Thank you. 86-year-old female from Sioux Falls, what can be done to protect and preserve vision in the elderly? Eric, the elderly are subject to macular degeneration. So we have a picture of macular degeneration coming on. Let's show how this little video of what macular degeneration is. And I didn't give them enough time to be ready. Here it is.
So basically, they're just showing what I see when I look into the back of the eye. The macula right there is the center vision, and you can see those little yellow deposits that they're putting on there, and that's what we call drusen, and those are waste products that begin to develop under the retina as we age. And what they're showing there is what we see when that turns into what we call the wet kind of macular degeneration. Because as the drusen develops and you get other degenerative changes, sometimes abnormal blood vessels can grow under the retina, and then they'll break through the retina and they'll start to break and bleed. And when that happens, you'll see the hemorrhage like you did in the short video there, and if it goes untreated, what they showed there at the end was a fibrotic scar. Basically, just over time, the center vision will just scar out and you'll lose all your center vision.
And you get more loss of the center vision.
Correct, yeah. With macular degeneration, the macula, basically, that's just the center part of the retina. That's the part of the retina.
And that's this part. This is the macular.
Yeah, really, we kind of think of it as this part right here. These blood vessels here are called the arcades, and we call it anything within the arcades basically.
Okay. And this is the cup where the nerve.
That's the optic nerve.
Nerve
Yep.
goes back, and of course that's a blind spot. Everybody reads about where you've got.
Yeah, there's no retina there. Yeah.
There's no retinas.
functioning retina there, I should say.
Which is all right. It's off to the side.
Correct.
But these drusen bodies can occur, and they are what?
Basically, they're waste products that the retina can't get rid of. So all these little spots you're seeing in here, all these little drusen, they'll form under the retina. And when that grows under the retina, that starts to damage the photoreceptors and other cells that are within the retina. And that's typically what we see as a regular aging process. But when you have macular degeneration, you're seeing more of that. When people get to about 70 years old, which this person that put the question in is a little bit older than that, about 30 to 40% of people are already going to have some of that macular degeneration. We tend to see it more in people of Northern European heritage.
Okay.
We've got a little bit of that in this part of the
Yeah, we
of the
do.
world.
Just a few.
So,
Just a few. And this is a picture of someone who has age-related macular degeneration. They don't see the center vision.
correct. Yeah, it doesn't affect the peripheral vision at all. So people
And
that
why
have,
is that? I mean, why is that?
because the macula is right in the middle.
And that's what gets the.
And that's what gets damaged with macular degeneration. So that's one thing. People always wonder, well, am I going to go blind from this? And that's the one good thing I can tell them when you have macular degeneration. It's not like everything's going to go black one day. Okay, it doesn't affect the peripheral vision at all. I have people with pretty bad macular degeneration, but it's progressed slow enough over their life that they've been able to slowly adapt and adjust to things and still, get along pretty well, actually.
I had a dear patient who passed away since, but who would come to my office and talk to me, and she'd be looking at me, but she'd be off in the distance.
Yeah, they call that eccentric viewing, and that's
Yeah.
and people just learn to do that over time.
Yeah.
But sometimes with that wet degeneration, that can be a very abrupt change.
So explain a little bit about it, wet versus dry, and what we can do for macular degeneration.
the dry degeneration is by far the most common type we see.
90%, something like that?
Correct. Yeah, and really, you can almost think of that as kind of regular aging change. Like we talked about, when people get to 70, everybody's kind of starting to show a little bit of that, and they do call it degeneration for a reason. That's because it degenerates. It gets worse with time. But when you get the wet kind, like I was mentioning before, you get these abnormal blood vessels that
Right.
grow under the retina, and they'll grow up through the retina, and then they break and bleed, and then that can cause scarring and hemorrhaging and can make the vision go down very rapidly. Back in the old days, before I was in training, what you would have to do is take a laser and fry that area, just kill it with a laser.
Right.
The problem with that is that gives you a permanent blind spot there forever. Never going to go away. You're basically sacrificing that part of your vision to save the rest.
So now,
We've got pretty amazing stuff. This is another thing we were taught, and this has just happened since I went into training. So we have medicines that we can inject into the eye that can make these abnormal blood vessels shrink and go away. So we can prevent the bleeding and leaking and scarring from the wet degeneration. We don't have a way yet to get rid of the degeneration itself.
Yes.
But it's been a life-changing thing for people, because people that come in with this wet degeneration, you used to pat them on the back and say, good luck, you're going to go blind, right in the middle there, and that's all we can do. And now I have people that can get their driver's license, can still do what they want to do with treatment for that wet degeneration. So.
all right. So we're going to get to your videos. I want to work our way through that. Let's get started on those videos, and then I'm going to have Vance talk about what we've got.
Well, this is an eye that's having cataract surgery with one of the major advances that's happened in cataract surgery is a laser to help with, removing the capsule, because the cataract sits in a capsule that's as thin as saran wrap. And we're going to remove the front capsule with laser. It's like a perfect cookie cutter, so that we can actually get to the cataract. Because the cataract sitting in the capsule, we want to preserve that capsule, because that's what's going to hold the lens implant also.
Okay.
It's a very delicate bag, and so you're going to see the laser help us with the capsule removal and also soften the cataract
Okay.
to ease its removal.
All right, next one. So here comes the capsule removal.
Yep, and so there's a little forceps, and there I'm removing the capsule. Normally we do that with a little circular tear. That's a pretty impressive maneuver you learn as a young resident in training. And so to see that you can remove the capsule that well with that perfect cookie cutter laser is exciting.
Okay. And then the next part is, are we going to be able to see this
And so the cataract's been removed, and now we're vacuuming that capsule, and the capsule's lined with a cortex, and we want to get that out so that you know that red reflex that you see in a picture? We want to make that red reflex look perfectly clear, and then that capsule that's as thin as saran wrap is going to now be able to hold the implant. And we about got all the capsule cleared up, and we're vacuuming out right there.
There it's gone.
Yeah, see how that red reflex is really nice and clear, and that patient's going to love their vision because of that.
All right, so that was another cataract surgery we just watched.
Yeah.
That's really neat.
Yeah.
All right, is there another part of that? That's it?
Just the implantation of the implant.
Okay, let's see the implant then.
And so we put in a little bit of what's called viscoelastic to inflate it. And we're actually going to polish the capsule. You know, I feel like we're teaching a bunch of eye surgeons out there right now because this is fun, intricate stuff, but those lens epithelial cells that make the fibers that, you know, make cataracts can also cause opacification of the capsule. And you've heard of the laser that happens after cataract surgery. We call it the YAG laser. And what I'm doing is I'm polishing those lens epithelial cells to make for you know, a nice clear capsule for the implant. And maybe we can just go to the next clip and watch that implant because it's fun to watch the implant actually go in. And here we're polishing the other side of the capsule. And we do that for 360 degrees.
So,
Isn't it amazing what we can do inside an eye though?
yeah, I mean, I think about the...
I did a bunch of it before driving here for this program today.
Yep, there you go. You did how many of those?
15 today, yeah.
Oh, wow.
So, yeah.
Okay.
So,
15 today.
Yeah.
Yep, and here comes the implant.
and now we're just reinstilling a little bit of that thicker substance, and we're going to inject the implant. And this is the part that's just the advancements that have been made. This is an implant that, you know, helps people see at multiple distances, and you inject it so you can put it in a small incision. And that's one of the, you know, wonderful advancements that's happened in cataract surgery is a small incision and how it helps the recovery.
You used to have to sew those down, though, did you not?
Right. Now they just sit in that capsule but in the same capsule that our natural lens sat, and it will be there for the rest of the person's life.
So, two more little videos coming up. So what are the next videos about?
You know, I'm not sure. I think that was it for me.
And the next one is when we
So now
we put antibiotics or something.
Oh, yeah. This has been a neat advance. At the beginning of the program, Eric talked about the pars plana, the area where the retina stops. And in that area is where we oftentimes can put an instrument inside the eye and not hurt the retina. And antibiotic eye drops are something that a lot of patients don't like taking. And I had, for instance, a Parkinson's patient that was just so worried about the drops, and we can just inject them, and then they don't have to take the antibiotic and steroid. And what happens is that's slowly released from the vitreous gel over the next 3 weeks. And if they've had a vitrectomy, then we recommend the drop method. But we teach patients about both ways.
Okay. And we're hydrating things on this time.
That's so you can do it without a stitch. Just rehydrating the incision.
Okay. All right. Well, let's dive into our questions.
Yeah.
Thank you very much for that. That's a wonderful thing. 71-year-old man from Custer has a floater in the back of his eye that moves with eye as he moves it back and forth. Is there anything that can be done to help it? Well, it's the vitreous separating from the back of the retina.
So like we talked about, floaters are normal. That's a normal thing. Everybody has some of that. The question is, how bad does that floater bother you? Because everybody has them. Depending on the lighting or the situation you're in, it may bother you more than other times. I remember in residency, I had a guy that was in the military that was a sniper. So anytime he looked through his scope, he was basically unable to do his job anymore as a soldier. So for somebody like that, or where it's absolutely vital that you have to have that floater out of the way, we can actually do surgery. And that's that vitrectomy that we talked about, where we can go into the eye and remove the vitreous. We don't have to do that very often. Most people tolerate floaters over the course of time, as the vitreous kind of continues to move and shift around, a lot of times they'll bother you for a while, but then over time they kind of shift out of your view and they don't bother you as much. Your brain's pretty good at adapting to things, and for most people, it just kind of takes it out of the equation and it doesn't bother you. But I get about one every couple of months where it's just a massive floater and it's just right over their center vision. They can't work. They can't do what they want to do. So those are the people we talk about that. But that's not without risk either.
The vitrectomy carries a risk.
It does. Vitrectomy speeds up cataract formation. So that's something you got to take into account too. Right. So.
Okay. 81-year-old man from Mina, bothered by floaters. That's a similar question. 81-year-old woman from Vermilion. Why can I only work at a computer for a short time before my vision blurs?
You know, I think when it comes to, when you're concentrating, like on a computer or when you're driving, your blink reflex goes down 30%. And tears are produced and stimulated by blinks and distributed by blinks, just like a windshield wiper on our windshield. And so, sometimes it's dry eye that's causing that. And sometimes it's something else. Sometimes people need a little bit of prism in their glasses to help their eyes work together. But the best thing you can do, and you should anyway, is get a yearly exam by your optometrist or ophthalmologist and make sure things are going okay. But there's definitely things you can do for computer blur.
And by the way, you mentioned that you're going to be hunting this coming.
Safety glasses.
Tell me about them.
It's one of the reasons that we're not fans of fireworks. We love fireworks displays where you sit back and enjoy that, but the eyes we see leave this world from fireworks or hunting accidents, and that's why safety glasses are so important.
So you should not hunt without glasses.
Well, I'll have a lot of friends and family with me this weekend, and nobody gets to hunt without their orange hat and their safety glasses. Yeah. And wear ear protection too.
Yeah. So, but do these glasses work for safety glasses?
Well, I actually like even larger glasses. They do work, but it doesn't cover everything just as perfect. So best thing to do is don't shoot at low birds.
Yeah. Make sure there's plenty of sky underneath that bird before you shoot.
Yes.
Any other comments about safety glasses?
No, I was just going to say that's usually whoever draws the short straw for the call pool is the one who gets pheasant opener.
Yeah.
So
the call pool.
Every year we get a few.
It's just so sad when it's preventable.
Yeah, exactly.
I had a patient. I was in the emergency room, and they were doing bottle rocket games, shooting bottle rockets at each other. And of course, one guy caught it in the eye and lost his eye forever.
Oh, yeah.
That was a terrible story. 66-year-old woman from Sioux Falls. What are the best things for relief for chronic dry eye? What's the cause? And is light sensitivity related?
Well, the tear film nourishes the surface, and when the surface gets irritated, light sensitivity is something that happens. And so it's important to get that eye exam. Dry eyes can actually become bad enough that it can cause recurrent infections, and it can actually hurt vision. And sometimes if someone has rheumatoid arthritis or some of these things like
diseases,
some like lupus or something, and it's been fairly progressive and they're getting dry, we need to be very careful about managing their tear film. So there's a lot of neat things you can do for the tears, like punctal plugs, artificial tears, nutrients, and so go in and get it checked. Lots of things to do.
Lots of things. What happened when you have a migraine of the eye with flashes in the light? Flashes in the...
what they think causes that mostly is very similar to what they think causes migraine headaches, actually. And a lot of people think that that's a vasospasm or a spasm of a blood vessel in the eye. And when people get those in their eyes, it can be kind of a weird deal because you'll notice these kind of shimmery lights or kind of what they call a scintillating scotoma. And that's where you can kind of get these shimmery lights. For a lot of people, it'll start right in the middle and kind of grow over time. A lot of people say it looks really pretty. It's almost like a prism. Yeah. And as that goes away, a lot of people will have blurry vision for a while after that, which can be worrisome because when that vision's blurry after an event like that, you think something horrible is going on. But almost always that comes back.
Comes back, almost always.
Yeah.
We'll be back. We'll be right back after this.
All around town, from stores to playgrounds, babies are on the move. And there are diseases that are on the move too, and some of these spread easily. To best protect him from 14 serious diseases by the time he turns 2 years old, vaccinate him according to the recommended schedule, so he can go on about his business and you can have peace of mind. For more reasons to vaccinate, talk to your child's doctor or go to cdc.gov/vaccines.
The second leading cause of irreversible blindness in the United States is from glaucoma. 3 million Americans are affected by this condition, and approximately 1 in 10 will eventually get it, although it's more common in people of African or Asian descent. The big question is, what causes glaucoma? I thought I knew the answer to this question, but the more I looked into this topic, the more challenging that question became. Glaucoma, by definition, is nerve damage causing loss of vision, which mostly affects the peripheral vision. That is, one can still see what he's staring at, but loses the parts of the vision outside that central concentrated spot. We think this is mostly due to an elevated pressure of the fluid within the eyeball, and so it's treated by using medications or surgical methods to lower the pressure. When glaucoma progresses, even the central vision can be lost. Well, to understand the reason for increased pressure within the eye, one has to first understand the construction of that human eye. Think about an enlarged 3D model. Begin with a white beach ball and line it with a light-sensitive blanket or of nerves called the retina. On the front of the ball is a hole called the pupil. A hole looks black since it's usually darker inside the eye unless a camera flashes. The pupil is outlined by the colorful iris that can constrict or dilate, making the hole smaller or larger, allowing just the right amount of light through to reflect on the retina. Imagine a magnifying glass-like lens smashed up against and behind the hole to focus light, and a smaller clear dome placed over the front of the ball to protect the pupil or hole. Realize both chambers of the eye are filled with fluid. New fluid is constantly being made inside the big ball, and old fluid flows or drains into the front dome chamber where it's removed. We think some types of glaucoma happen when the optic nerve is damaged by fluid pressures inside the big chamber becoming too high and tight, sometimes because the fluid-removing canals are plugged, and sometimes because flow into the front chamber is blocked. And there are several reasons for that blockage. Boy, is this complicated. And to make it even more confusing, sometimes glaucoma nerve damage happens while pressures inside the eye are normal. Go figure. Once again, physicians and scientists are puzzled and are still searching for the complete answer to the question, what causes glaucoma? A heartfelt thanks to our studio guests, Vance Thompson of Vance Thompson Vision in Sioux Falls and Eric Thomas of Ophthalmology LTD in Sioux Falls. And thank you at home as well. We generally appreciate your participation and discussion and hope you learned something tonight that'll help you see the world a bit more clearly. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
Your family's health is important to you and to us. We're open to your calls and emails about whatever subject concerns you when it comes to your loved ones. It's Ask Anything About Family Health. Next time on Call with the Prairie Doc.
Welcome to On Call After Hours, where we answer the questions we weren't able to get to during the broadcast portion of our show because we just had such a good time and lost track of all of these things. So that's what's happened. All of your questions are important to us, and we want to answer as many as we can for you. And we had a bunch of them. So let's fly through these questions. 89-year-old woman would like to know why her eyes water in light, especially in fluorescent lighting, and she has dark circles under her eyes that look like black eyes. So fluorescent lighting, either one of you?
Well, fluorescent lights can be more sensitive to people with dry eyes, so you want to be assessed for dry eyes by your eye care specialist, but also with the black circles, there's wonderful cosmetic things that can be done to help that.
Okay. 70, and so go to your eye specialist and
Yes.
look at that. Here is a question from Brookings, left a year ago, 93 years of age, man, had my left eye started to tear up, right eye's now starting. What's the cause? Should I be concerned, Eric?
Actually, that sounds a lot like dry eye also, to be honest with you. I know it doesn't make sense that your eyes water when the eyes are dry, but the eyes make different types of tears. There's tears that lubricate the eye, and then tears that are reflex tears that wash stuff out of the eye. So it could be something as simple as dry eye, but you can actually get blockage of the tear ducts also, and that would be something, especially in that age group, that he may want to get that evaluated if that's continuing to be a problem.
Go to your eye doctor.
Correct.
72-year-old man from Sioux Falls, right eye tearing up. We did that. And he said walk-in clinic diagnosed epithelial lacrimal excess. What's that and why did it happen?
Well, I think Eric just answered it, wonderfully, and that is, it's amazing how a dry eye can send a message to the brain that it's irritated, and the brain make irritated tears.
Okay.
So get that tear film checked out.
Get it checked. 85-year-old female from Corsica had cataracts repaired and lens changed. Now eyes water profusely when reading. Gosh, same story.
So this is a common complaint in
It's a big
any
complaint.
field of ophthalmology. Dry eye is a big deal.
But you need to check the eye tears, the kind of tears that you're having, right?
And there's great tests for that, to measure the right balance of tears and treat it properly so you don't have to live this way.
And so there's special eye drops depending upon the kind of problem.
Exactly.
So see your doctor. 60-year-old woman from Pierre. I have a very beginning of macular degeneration. Is there any new treatments in the horizon for this? And is nicotine gum harmful to your eyes? A lot of people think multiple vitamins with the special Bausch & Lomb, very expensive, all these special supplements. I think it's pretty weak data and only works, proven scientifically, with severe end stage. You agree with me on that?
The type of vitamin you should get is called the AREDS 2 formula. That's the most up-to-date formula. That stands for the Age-Related Eye Disease Study 2. They did a second one that's more up-to-date now. I don't care what kind of brand you get, is what I always tell my patients, as long as you get that formula. And that has been shown to decrease your risk of wet macular degeneration and also helps slow down the degenerative process. But you're right, it's only for people with moderate to severe macular degeneration. So people that don't have it, you don't need to take it. It's not going to stop you from getting it. Even if you have a little bit of early macular degeneration, not going to be overly beneficial. However, a lot of my patients take it anyway. So
I say a good lifestyle, a regular exercise program, and a balanced diet. There's my answer.
that every study has also shown that to be a good thing.
Wabe, 77-year-old man, could talk about retinal wrinkle causes treatments.
Yep, a wrinkled up retina is usually from a membrane growing on the surface of the retina. And just like a scab on your skin, as it kind of tightens and pulls, these membranes can pull on the surface of the retina and wrinkle it up. Usually, if it's not too bad, you can live with it, but a lot of times for people over time, it'll get worse. And the only way to address that is by having an outpatient surgery to go in the eye and actually peel that off the retina.
Yeah. What kind of symptoms do they have?
Distortion in vision or blurry vision are the two most common
All
causes.
right. 60-year-old woman from Lake Wilson, Minnesota. My mother-in-law has a detached retina, is losing her sight. Is there anything to be done for that, Eric?
Yeah, she should be seen immediately and probably have surgery to fix that.
And they spot weld. They spot weld.
Well,
the
if she
retina.
actually has a retinal detachment, that usually, if it's a retinal tear, a lot of times we can laser around that and kind of spot weld it down before the retina detaches. There's lots of different types of detachments, but if you know you have a retinal detachment, you need to be seeing a retinal specialist and seeing if there's something they can do to prevent that from getting worse.
76-year-old woman, explain open-angle glaucoma.
Basically, the
We've
fluid,
kind of done that,
Yep.
but say it one more time.
Yeah, well, the angle is the area right where the cornea meets the iris, and that's where the drainage channels that we call the trabecular meshwork are. And if the drainage channels are nice and open, but you still are having a hard time draining the fluid, we call it open angle glaucoma, and there's medications and surgeries to help that.
Okay. 80-year-old man from Rapid City has a question of wet macular degeneration. What's the material that's being injected into the eye and how does it work? And can you stop it after you've fixed it?
Like we talked about, those injections we inject into the eye, those are called anti-VEGF medications. What VEGF is a chemical that stimulates blood vessel growth. So basically, you can kind of think of it as when you put this medication into the eye, it makes the abnormal blood vessels shrink and go away. So I'll tell patients a lot of times it's kind of like spraying Roundup on a weed. It makes those vessels shrink down and regress, and hopefully by continuing treatment with that, you can keep those vessels from growing back.
But you have to,
yeah,
you start, you got to keep going.
You do. However, we usually do what we call a treat and extend model. All the initial studies said, boy, you got to be on that a shot a month forever. Nobody does that anymore. It's just not realistic. And what we do is we treat it till it's under control. Then we slowly try to spread out the interval between injections until we can find a happy medium between keeping it under control and not having to poke people so much.
All right. Del Rapids, 75-year-old woman wants the doctors to talk about glaucoma, laser surgery versus the one where you place a shunt to relieve the pressure.
Well, you can do a laser from the outside of the trabecular meshwork without going in the eye. Lasers will go through the cornea and treat that trabecular meshwork. But you can actually do certain lasers inside the eye where you're actually treating the areas that make the fluid, and so you can lessen it. So there's a couple ways that lasers help in both drainage and production.
All right. Here's a woman with wet macular degeneration, received Avastin injections, is going to carry on for the rest of my life, or will it stabilize? We just answered that. 70-year-old woman from Arlington. What causes blood vessels to break in the eye? It's when they're fragile.
I mean, that's a pretty broad question. I mean, you can get hit in the eye, you can have trauma, you can have abnormal blood vessel growth where they're fragile and break and bleed. Those are probably the two most common causes we see. 64-year-old woman. Oh, someone is using Restasis and BBL. Neither have seemed to help. Are there other options?
Oh, definitely. And so those are important dry eye therapies. There's definitely things like punctal plugs where you plug the drain so your own tears don't leave the eye so quickly. And there's other options, but sometimes you treat all the dry eye stuff and you still feel dry eye and eye strain. And sometimes you need prism in your glasses to bring the images together because you're straining all day to make the eyes work, and it leads to the sensation of dry eye that it isn't always dry eye.
Okay, and so sometimes the eyes are in different planes. Why does that happen?
Because of eye muscle imbalances is one of the reasons, and then also how the images are presented to our brain. Remember, we have two eyes, and there's two images that have to blend together in the brain, and they don't always blend perfectly. And sometimes the brain has to resolve that disparity, and it can lead to these symptoms of dry eye, computer vision syndrome, even frank headaches.
Headaches, a lot of prism problems and headache problems.
We call them eye grains.
Eye grains, yes. 68-year-old male from Yankton. What causes recurrent corneal erosions?
Well, basically that's a loose epithelium on the surface of the cornea. It's something that I actually treat commonly. And so the epithelium is a layer that covers our whole body, and including our corneas. And when the anchor isn't good enough and you go to sleep, your eye dries out, your lid sticks to the epithelium, and you wake up and your lid can pull it off. And you can treat that with a laser and reestablish normal epithelial adherence. Before we do a laser, though, we try to treat the dry eye that's causing the stickiness.
Right, maybe a plug like you just said. And
yes.
Dry eye, that's amazing. We had so many questions.
Yeah.
Keratoconus, a son with keratoconus, an 81-year-old woman from Sioux Falls, the cone shaping of the cornea, doesn't understand it and asks to be,
This is a really important problem of the cornea. Most common reason is eye rubbing. People will rub their eyes and create a thinning and irregular cornea, and then it blurs their vision. But some people, it's not eye rubbing. They're just born with the tendency. But it's from a weak cornea, and it's actually been one of the big areas of my research, is collagen cross-linking to strengthen the cornea. So I actually see a lot of keratoconus patients that you can strengthen that cornea. If it's progressing If it's not progressing, we try to treat it with a contact lens and try to help them not need a corneal transplant, which is always an option.
Okay. Deep-edged retina. What's that?
I don't know what that is.
Okay.
That's somebody using a term with this person that I'm not sure exactly what they mean. It could be that they're real nearsighted, and sometimes in the back of the eye where the optic nerve comes in, it can be very kind of deep and steep, but I'm not really sure what they mean by that.
And what do you do if it were deep and steep?
Nothing.
Glasses.
That's just the way their eye is made, and you correct for the refractive error that they have.
Okay. Gas permeable contact lenses lost in one eye, found 20 months later. Is that common?
No, that's not common, but it is amazing what you can find under an eyelid
That's been hanging around for a
year or
long
two later.
Really?
Oh, it's just amazing what we find. So we're trained when someone's having drainage from their eye or redness to lift the
up
lid.
underneath there.
Yeah, we look real good. But I've heard of this happening.
Foreign bodies, though.
I've
I mean, other
taken
things.
them out of people.
Yeah. But other people can have pieces of junk that are floating there and they just don't clear them. Probably dry eyes
Correct.
again.
Correct.
Car keys or things like that. Has a pseudo hole in the back of her eye and wants the doctors to explain it a little bit more. Pseudo hole, 85-year-old woman.
Basically what that is, people that get a macular hole, which is where a full thickness hole in the retina develops right in the center vision, the part of the macula.
Yeah.
A pseudo hole, when you look in the eye, it looks like it, but it's not actually a full hole all the way through the retina. That's why they call it a pseudo hole, because it's not a real hole. A lot of times it's from a membrane growing on the retina, kind of pulling the retina up a little, so it makes it look like there's a hole in the center area. Typically, those don't really affect the vision too much, and we don't have to do surgery for those. People that have a hole all the way through the retina, what we call a full thickness macular hole, those people do have to have surgery to repair that.
What, you sew them up?
No, you don't sew it up.
pull
You
the
go
hole
in,
together.
actually you go in and you peel the membrane off around the hole because it's just being pulled apart. It's not like somebody cut a piece out and threw it away.
Oh.
So if you can get rid of the traction that's pulling that hole open, it'll grow back together.
All right. Creighton, Nebraska, when she, 86-year-old woman, sees a printed word, part of the word will be up and part will be down, what causes distortion in the vision of a word, and it corrects itself after 5 minutes, has a pituitary checked, arteries checked, MRI, and all were normal.
That can actually be a symptom of dry eye. You can get goofy vision like that, especially if it corrects on its own over
Right.
time. That's the first thing that would
Dry eye.
enter my mind. However, 91-year-old, macular degeneration. That's one of the most common complaints we hear is distortion in vision. Some people, when they're sitting in a certain situation, they'll notice that, but like we talked about, your brain's pretty amazing. And a lot of times it'll kind of adapt and you kind of get used to that a little bit. So.
I have a 90-year-old woman from Ethan, South Dakota, had the biggest surprise of her life when she turned 90 in July, woke up one morning, couldn't see out of the left eye. Doctor told me I had a stroke, needed 3 shots over 3 months. After the second shot, vision improved by half. What causes this stroke? And how can I prevent this from happening in the future? Is there something I shouldn't eat?
Don't have to worry about the eating, that's fine. What she's talking about there is probably what we call a retinal vein occlusion, and that's the main blood vessel that drains blood out of the eye.
So it's not arterial, it's the venous.
What she's talking about here, yeah, if it's arterial, we don't do injections for that typically. What's going on is the blood vessels draining blood out of the eye, there's an occlusion of that. The most common cause for that is getting up in age, systemic or body high blood pressure, not pressure in the eye, and diabetes. Those are real common causes for that.
Wow. Okay. 77-year-old male from DeSmet, go Bulldogs. What are the doc's opinions on the over-the-counter Preservision?
They're talking about that AREDS 2 formula. Doesn't have, the Preservision is just a name brand. You can get any brand you want as long as it's AREDS 2, and that's just for people with moderate to severe macular degeneration.
71-year-old male from Sioux Falls. Dr. Holm is wearing glasses but has had eye surgery, is wondering why he still needs to wear them because he thought that if he had surgery, he didn't need to have glasses anymore.
Can I answer that for you?
Yes.
Because you chose to. And there's 2 ways to perform cataract surgery. One is where you're okay with wearing glasses, and the other is technologies where a person wants to do a lot without glasses. You look good in glasses, you enjoy glasses, you had a beautiful cataract surgery, and by choice you wear glasses.
And I have bifocal vision that allows me to see close because I'm doing this all the time. I was going to do that anyway.
And I do think it's important to just remind that people have a choice. You know, they can do a lot without glasses or a lot with glasses type cataract surgery.
Right, and my vision is way better than it was before the cataract surgery. 66-year-old female from Sioux Falls diagnosed with Fuchs dystrophy. Discuss and explain implications and treatments. That's yours.
Well, Fuchs dystrophy is something that happens to the cornea, that front clear window, and there's a layer on the back of the cornea that if you look with a microscope, it looks just like a honeycomb. So again, the cornea is the front window of your eye, kind of like the part of the window inside your house or inside your eye. It has this layer sucking water out of the cornea into the eye. And if that layer that's pumping out water gets, Fuchs corneal dystrophy, you lose some of those little water pumps. So the cornea swells. And then if it swells enough, it blurs vision, and those cells can be replaced. In the old days, it was a full thickness corneal transplant. Now you can replace just those cells, and the recovery is a lot quicker to treat Fuchs.
Well, okay. We have nevus. I have been told I have a nevus. Does this need treatment, and what is the treatment? I've got a couple nevuses.
Yeah, those are real common. Just like you can get a freckle or nevus on your skin outside your body, we see them inside the eye all the time. Anytime you see a nevus in the eye, you do have to have that monitored, because just like the ones on your skin,
they can turn to malignant.
They can grow into bad things. Doesn't happen very often, but we have patients that can develop typically what that turns into is a melanoma. And those are the most common primary tumor we see in the eye, except for retinoblastomas in little babies. So
okay.
They need to be dilating that patient, looking at them once a year at least. So.
Yeah. And so what do you do if it looks like it might be malignant melanoma?
Then typically what we would do is have you see an ocular oncologist. You would think a corneal specialist and a retinal specialist would be enough.
Yeah.
But there's actually people that do ocular oncology, and we would get you to one of those people, and there's different ways you can treat that. Everything from as severe to remove the eye to where they take little radioactive plaques and sew them to the outside of the eye for a specific amount of time just to treat that lesion locally. So.
Wow. Devic disease. Devics. So what is Devics disease?
You can kind of think of it like multiple sclerosis a little bit, except it hits different parts of the spinal column. As far as eyes go, a lot of times we can see inflammation in the eye, and that's what we call uveitis or iritis. Sometimes we'll call that pars planitis. When we see that in patients, we have to worry a little bit because that can be associated with other systemic conditions. So somebody that has Devics disease could possibly have uveitis or inflammation in the eye. So from an eye perspective, we want to be looking for that, but they need to be seeing a neurologist to be talking about different types of treatments for that.
Well, what's going on in the brain?
Correct. It's what they call a demyelinating disease. So.
Right, but also if you have rheumatologic conditions that can cause uveitis.
Absolutely, yes.
So,
we see a lot
which
of that.
means inflammation of the uvea.
Correct.
Which is the retina.
Retina, iris, ciliary body.
All of it.
Correct.
There it is. Uvea is the same as a lot more.
Yeah.
Armour, South Dakota had cataract surgery. Cataract surgery a couple years ago. I now have a floater. Does this have anything to do with it? She's 78.
Chances are no, but anytime you do any surgery on the eye of any kind, if your vitreous is about to pull free back there, any sort of procedure could kind of induce that to happen, but cataract surgery doesn't typically cause floaters.
Okay, 16-year-old amblyopia. Are there new treatments? Let's see, 72-year-old male from Rapid, 16-year-old amblyopia. What are the treatments? So amblyopia, do you understand that?
Yep. So amblyopia occurs when someone has something blurring the image in their the early years of life, typically from birth to 7, 8 years of age, is where the vision part of the brain, or cortex we call it, is developing. And if the brain's being presented a blurry image that hasn't been corrected with glasses, or if the eyes are turning in or out, and we see double as adults, but little babies and kids will just turn the image off, and so the brain's not going to develop vision. That's why you want these children to get in for eye exams, and they develop reduced vision because of a brain cause, not an eye cause. The eye is actually oftentimes very normal. And so, they'll use patching of the good eye to try to get the
Bad eye to
work to see, and they'll try to get the glasses to correct the high astigmatism or whatever it is, or straighten the eyes out. But there's some great treatments. But after you lose it, getting to 16 years of age, there's oftentimes not anything you can do.
Use it or lose it.
But you still want to protect your other eye, and you still want to protect that eye. So yearly exams are very important.
Wow. That's what you're talking lazy eye, though, right?
Yep.
That's 86-year-old from Centerville. I have a problem with getting sand or grit in my eye after cataract surgery. It causes the granules.
Dry eye.
It's dry eye.
Yes.
And it's just part of getting older, and there's these other rheumatologic diseases that set you up. But
And there's so many options to treat it, and it's one of the most undertreated things in eye care today. And so there are great options. Go get it checked out.
all right. Crofton, Nebraska. I've had a lazy eye all my life. What can be done? Lazy eye. We just talked about it.
Correct.
And is there anything to do now? I mean, there's some muscle things that you can.
No. I mean, you still, let's say you had a 20/50 vision lazy eye, and you now have a 2200 cataract. Sometimes you can, help it with other things to get back to that original vision that the lazy eye has. But in general, you can't help the amblyopia. You can't help the lazy eye. And you want to protect the other eye, and you want to get yearly exams.
Okay. 72-year-old man, eye doc, says optic nerve has swollen. Is it serious?
Could be. The optic nerve can look full and be normal, or it can be swollen. There's lots of reasons that the nerve can be swollen. Anything from blocked up blood vessels like we talked about before, from maybe a tumor growing behind the eye, in the head, increased pressure in the head.
Brain thing.
Correct. But a lot of times you can look at the nerve and it kind of looks swollen, but it isn't necessarily. It's just kind of what we call a full nerve, or sometimes you can get little calcium deposits that grow in the nerve and make it kind of pooch up a little bit, makes it look swollen. But if they're seeing that it's swollen, they need to be checking that patient's vision to make sure there isn't other things going on along with it. So.
Okay. 64-year-old woman from Rapid, lupus has damage to her optic nerve in both eyes due to lupus and lupus medicine. Does she have hope for optic nerve to be able to be repaired?
That's tricky, and actually what they're probably talking about is the medication Plaquenil or hydroxychloroquine.
Yeah, from the medicine.
Is used for lupus, but that typically doesn't damage the nerve. It's usually a retinal toxicity, not a nerve toxicity. And that's why typically when people are on Plaquenil, they need to be getting checked annually for that. The risk of toxicity of that medication is really, really low, especially with the doses we use now.
Yeah,
but I'll get a couple people a year that are showing some signs of that. So usually, though, the damage from that can't be reversed.
It's an irreversible thing.
Correct.
This is a 29-year-old man from Brookings, a patient who consistently has high blood sugar. Please explain more about high blood sugar immediate affects the retina other than just diabetic reasons.
What Vance talked about earlier, the lens swelling is probably the main
The
issue.
sugars are high, mess with the lenses.
Yep.
59-year-old woman from Brandon, eye disease called amaurosis fugax. Ophthalmologist told to get kids checked as this might be inherited. Is there something that develops with age? I got checked 8 years ago. Should I get it checked again? Amaurosis fugax.
Well, that specific term is is reserved basically for when people get poor blood flow to the eye due to lack of flow from the carotid artery. So that's usually not an inherited thing, but people that are having that, if the carotid artery is occluded enough in certain positions, you can kind of pinch off flow, and that can make blood flow to the eye decrease and makes the vision suddenly kind of go dark for people. So if she has something like that, she definitely needs to see her regular primary doctor.
Make sure
they need to be doing carotid Dopplers and other tests to make sure there's not a blood flow issue. But usually don't have to worry about that being a hereditary type of an issue.
Okay. If I lay on my pillow just wrong, everything goes black. Well,
that should be a warning flag.
Symptoms when you have cataracts, Vance.
They can be anywhere from reduced image quality in low light to nighttime glare, to blur, to sometimes ghosting, not quite double, but a ghost image, and sometimes it can even be double vision.
Okay. How much does genetics affect vision? Father has macular degeneration, mother glaucoma. Should I be taking eye vitamins? 59-year-old woman.
No, she shouldn't be taking eye vitamins is the first answer. Genetics that's kind of a budding field right now. We do know there's definitely genetic markers that make people at higher risk for getting macular degeneration earlier in life and more severe early in life. But typically, we don't do genetic testing routinely right now because we don't do that test and then say, okay, well, you have this, we're going to treat you with this now. We don't have the connection between testing and treatment yet. But they're doing a lot of research on gene therapy and other things like that. And that is something that's not science fiction. We're doing that in people right now. So that's going to be something in the future that's going to continue to grow.
My sense is that lifestyle of a regular exercise program and a proper diet, if you're obese, I don't think anybody has great success in losing weight, but you can be an exerciser no matter what weight you are. And you just do it gradually and stay exercising and eating correctly, a balanced diet. I think that's the best thing.
Absolutely, yeah.
Nearsighted all my life, my correction always seems to be changed, but the last 5 or more years my eyeglass lenses might be strengthened, but my correction is never good. I have to pull my glasses away from my eyes just to see better. Does this mean my vision is getting better instead of worse, so my lenses should be weaker rather than stronger?
Well, basically you need a good eye exam. If it is a retina issue, you want to know. And sometimes when you're pulling the glasses, further from the eye, it can change the magnification and maybe make you feel like you're seeing a little bit better. But the bottom line is you want to get a nice corneal topography of your cornea, make sure it's not developing keratoconus, you're not an eye rubber, and that you're not getting early cataracts. A good thorough eye exam can help that situation.
I see people rub their eyes all the time. They just kind of get into a habit, and they just do it as a kind of a habit thing. It's a bad habit.
I ask every patient if they rub their eyes because it can weaken the cornea. The zonules, the lens, that are so important to stabilize our lens even after cataract surgery, they can be loosened by eye rubbing. People that have the weakening in the back, the deep retina, we call it a staphyloma. Eye rubbing can hurt those things. Eye rubbing is bad. That's why you want to treat the allergies. You want to treat the dry eyes so you don't have to rub.
Okay. Wow. 63-year-old, I'm unable to have LASIK surgery due to extreme dry eyes, but I'm developing cataracts at different rates. Not bad enough for surgery yet. Will having this surgery cause further issues given my dry eyes, and do they really put one lens in for far sight and another for near sight?
Well, it sounds like you went to a good LASIK surgeon that said you shouldn't have LASIK because of your tear film. You can treat that tear film. And as far as cataract surgery, you don't need to do it until your glasses aren't giving you the image you want. But when you're not getting the image you want, do the cataract surgery. And you don't have to have one near and far. You can have it however you want. You can have both far, you can have both near, you can have one of each, and it's worth a good discussion about which option is best for you.
I need to wear contacts that cover abrasions my doctor says may never go away. Wearing contacts get really uncomfortable because my eyes dry out and or the contacts get gummy and dirty. My doctor says my dry eyes are because of evaporation, not that I don't make enough tears. I do put drops in, but it seldom makes the contact wet enough after they dry. Do you have any ideas?
Well, this person has some great options. And yes, you can have evaporative dry eye. But the eyelids make a greasy substance, we call the meibomian glands, make a greasy substance called the meibum. And it's almost like Crisco. And it's the outer layer that prevents the evaporation of tears. And you can treat that layer. And you can increase the production of tears. But to constantly wear a contact for erosion puts someone at the risk for an infection and a corneal ulcer. And what you want to do, just like the earlier question on recurrent erosion or breaking down of the epithelium, treat the tear film, and if it doesn't heal, you can laser and reestablish normal epithelial adherence, and then wearing a contact lens is a choice, not a therapy.
All right, good. I have macular degeneration. My optician suggested AREDS 2 eye vitamin. I have a friend that has macular degeneration. Her doctor said MacuHealth with LMZ3, a natural eye supplement that helps prevention of age-related macular degeneration. As I got to sneeze.
Bless you.
As do old standards such as vitamin A, beta carotene in carrots, omega-3 fatty acids, fish oil, flaxseed oil, lutein, alpha lipoic acid, and bilberry. I would appreciate some information.
Yeah, the problem with the supplements is the studies that people do are very unreliable. There's no FDA approval of that stuff. The AREDS 2 study is by far the best study they've ever done on any of that stuff. So you're going to be, as a retina specialist, that's what I tell my patients to take. In fact, that AREDS 2 study showed, they actually took beta carotene out of that supplement in the AREDS 2 formula because that inhibits the absorption of the lutein and zeaxanthin that's in there. They also took out the omega-3 fatty acids because they found out that really didn't have an impact either, which goes back to your talking about a good diet. Populations that eat a lot of fish, a diet that has a lot of fish, do better with macular degeneration. So we know it's not just the omega-3s, it's the food itself. It's the food, yeah. It's not just the omega-3. Now, omega-3s can be used for a lot of other things, but specifically for macular degeneration, that most recent study showed it's probably not as helpful as we initially thought it was.
Okay. Nutrition, water consumption underestimated in the care of the eye, and if so, could general optometric education care encourage this? So how important is drinking all this water? I know that everybody and their dog are encouraging people to drink water. I personally believe that you should drink water when you're thirsty. I think we've overdone it. My most common drug that I prescribe is a diuretic for all sorts of reasons. And so I haven't encouraged people to drink or push water. I say if you're thirsty, drink water, but unless you're demented, you can tell yourself when it's time to drink. Do either one of you disagree with me?
Well, on my end, you're the specialist at that.
Okay.
So we would be asking you, and there's nothing eye-related that we would say anything different than what you just said.
Okay.
Drink when you're thirsty.
Yeah.
Yep. All right. Do you see any effects of increased technology screen time on the eye facilitating the condition? Screen time causes trouble.
I think Vance talked about that earlier, just dry eye issues. You know, when your blink reflex goes way down, we see more and more of that. I'm seeing a ton of that from a standpoint of macular degeneration patients because they're all using their iPads and Kindles and jacking that font up so they can read it better.
Yeah. Oh, yeah.
So they're, you know, when we're talking, we blink all the time, but when you're doing stuff, you don't.
You don't drink.
So we all, I mean,
Blink.
I think we all as ophthalmologists talk about that issue a lot, and obviously we have tonight.
All right, scleral lenses treat dry eye. Would you try other remedies first, and punctal plugs and counter drops, and what about over-the-counter drops?
Yeah, I would definitely consider scleral lenses more towards the end of the line type treatment. Try all the other things first, but it can be a way for severe dry eyes to trap what tear film they have against the cornea and protect from some of the environmental influences.
How about the eye drops that take the red out?
Well, we're not a fan of those, you know, because what they do is they have vessel or vasoconstrictors in them, and then when you quit using them, you can get a rebound effect. And so we ask people to not rely on things like that.
Visine or whatever.
And to really use lubricants under the direction of their eye care specialist, because another thing that people can do is be putting in drops that have a lot of preservatives. And in general, I say you don't want a preservative on your eye more than 4 times a day. And so if you're using these preservative drops so much because you wanted the big bottle, and you know it's got to have a lot of preservatives so it doesn't get infected, and it can be bad on your eye. So you want to ask your eye doctor.
62. What is a keratectomy?
Well, a superficial keratectomy, kera is the Greek derivation, that's the cornea. And ectomy, we're removing a little bit of the cornea, superficial on the surface. So sometimes when people have a scar in the very surface of the cornea, or they have recurrent erosion, superficial keratectomy is something that can be done to treat problems in the front of the cornea.
This person has a branched vein retinal occlusion, BRVO. Suddenly lost all sight in one eye 4 years ago. I refused suggested injections of the eyeball with Avastin, learned they were off-label. Luckily, vision in that eye slowly returned, much improved. Certainly not normal. Wet age-related macular degeneration, is this the same? Is that problem likely to return? And cardiovascular problems, do they run together?
Macular degeneration and a BRVO, 2 totally separate things. BRVOs, those vein occlusions we talked about, in some people you can get lucky and other blood vessels can start to shoulder the load for the blocked one. But like that person mentioned, probably not going to get full resolution. Every once in a while we'll get somebody that gets lucky, but the injections, and when they first came out, that medication Avastin, it was initially designed to be treating colon cancer. And the way it works is by making blood vessels shrink away from the tumors, and that's how they killed off those tumors. And some smart eye guys figured out how to put that in the eye and get these factors to go away that cause all the swelling and things that you get with those vein occlusions. So probably would have done a little bit better with the injections.
The injection might have helped.
Probably, but sounds like he ended up doing okay. So
I do think it's worth saying that off-label doesn't mean bad. When something is specifically FDA approved, it gets a specific label. And when we find other uses for it besides its labeled use, it's called an off-label use. And it's very legal to do off-label treatments. When we use aspirin to treat, joint inflammation, we're using that aspirin off-label. And so off-label doesn't necessarily mean bad.
And specifically for Avastin, that will never be on label for anything in the use in the eye, because the company that makes that has a much more expensive product that they want you to use. So they will never even seek FDA approval for that ever.
So you use Avastin because it works
It depends on the patient. There's 3 different types of those medications we use. The one I use most is Avastin, but there's 2 other ones called Lucentis and Eylea, and that's all very patient specific.
And it makes me boiling mad that the pharma has manipulated this in such a way. Give me a quick answer to an eye drop that I could use if I have dry eyes over the counter as a over-the-counter safe option instead of Visine.
Well, I like Sustain, I like Blink Tears, I like Refresh. There's great, TheraTears are awesome. I'm a big fan of preservative-free, so even though it's a hassle to twist off the top of the little dose and put it in your eyes, you can put it back on and get 3 or 4 more uses out of it. And I prefer preservative-free. And if you want a little thicker, Celluvisc. It's almost like 1040 weight oil. It's not as bad as an ointment, but boy, can it be soothing.
And put it in at night. So that's great answers. I think there's some long thank you guys, and you saw those. It's been a great pleasure to have you here. Thank you so much for joining us and answering these long lists of questions.
I'm bummed I didn't see the thank yous.
Oh, yeah.
I took it off my screen.
But thank you.
And thank you for joining us on our website. We appreciate all of your questions and the opportunity to answer them. And until next time, stay healthy out there, people.
Funding for On Call with the Prairie Doc is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota.
Additional funding is provided by Aberdeen Asthma Allergy, Brookings Health System, Dakota Allergy and Asthma, Dakota Care,
and the Orthopedic Institute, Physicians Care Sanford Clinic Community Service Committee, and Swiftel Communications.
Closed captioning for On Call with the Prairie Doc is provided by the generous support of
Avera, Brookings Health System, and the Fishback Financial Corporation.